Nephrotic syndrome is fairly common in children. I'm going to be talking about the practical aspects of management in OPD. Most children with nephrotic syndrome present with edema. Edema itself gives us a very good clue about nephrotic syndrome. Many parents bring their children to the OPD saying that there is puffiness noted in the eyes. The site of the puffiness will give you a clue as to whether it is nephrotic syndrome or no. Most children who have puffiness below the eyes are unlikely to turn out to have nephrotic syndrome. This is usually seen secondary to any upper respiratory infection, any fever, or in older children because of late nights. Puffiness that is present above the eyelids usually turns out to be nephrotic syndrome. The second feature of edema that one needs to note is the onset of edema. An explosive onset of edema usually signifies minimal change nephrotic syndrome or steroid sensitive nephrotic syndrome. An insidious onset usually indicates a non-minimal change variety, which is more severe in nature. What do I mean when I say explosive? When you ask the parents about edema, they will be able to tell you exactly when the edema started. So it will be probably 8 days ago, 15 days ago, 20 days ago. Whereas when there is insidious onset, the parents are not very clear, and therefore the history is that probably there for a couple of months or 3 months or so. Once you've got over this hurdle of edema, you obviously send a urine test to determine whether there is nephrotic syndrome. You are going to find protein in the urine in the presence of nephrotic syndrome. What often confuses us is the presence of a few RBCs or pus cells in the urine. Just because a few RBCs are present in the urine does not change your diagnosis. 10% of minimal change or steroid sensitive nephrotic syndrome will have microscopic hematuria. Gross hematuria is not a feature of the usual common nephrotic syndrome that we see and needs to be investigated further. In microscopic hematuria, you can treat them as nephrotic syndrome, but remember to keep a long-term follow-up. Similarly, if you see a few pus cells in the urine, it does not indicate a urine infection. Unless there are symptoms that are suggestive of a urine infection, pus cells in the urine for nephrotic syndrome only indicate an inflammatory process and should be ignored. Once you have diagnosed nephrotic syndrome, you are then going to treat them with steroids. So prednisolone at the dose of 60 milligram per meter square per day or 2 milligram per kilogram per day is what is usually started. It is important to note the time of remission in the first episode of nephrotic syndrome and note it down in your written notes. This is important because it has an impact on further management of these children when they have relapses. To give you an example, as my article and study in the Indian Journal of Kidney Diseases showed, levamisole, which is used to treat frequent relapses, overall has a success rate of 50% in nephrotic syndrome. However, if you now divide the children into two groups where the response is less than 10 days or the response is more than 10 days in the first episode of nephrotic syndrome, there is a marked difference between the two groups. Children who have shown a response in the first episode of nephrotic syndrome in less than 10 days and have less than 3 relapses in 6 months respond magnificently to levamisole up to 90%. Whereas children where the response has occurred after 10 days in the first episode, there is less than 10% response to levamisole. Hence, it is important to note the time of remission in the first episode of nephrotic syndrome. Similarly, it is also important to confirm that the child has steroid sensitive nephrotic syndrome by getting a urine protein creatinine ratio when you think the child is in remission. Mere disappearance of edema does not indicate that the child has gone into remission. Once the steroids are given and the child has gone into remission, the child can present back with a relapse. Now, a relapse may be missed if we use the usual tests of a urine routine or dipstick, because sometimes these do not indicate the 2 plus protein that we are looking for. Relapses can often occur in the absence of edema. And remember, a urine routine or a dipstick is a semi-quantitative test. So a high pH will give a high protein reading, a low pH will give a low protein reading. Similarly, a low specific gravity gives a low protein reading, whereas a high specific gravity gives a high protein reading. So in order to diagnose a relapse, you may have to take recourse to a urine protein creatinine ratio, which is a quantitative test and therefore tells you whether the child has developed a relapse. A urine protein creatinine ratio, which is more than 1 when both are measured in milligram per deciliter, is significantly high. Children who relapse after the first episode of nephrotic syndrome can either have frequent relapses or infrequent relapses. So those who relapse more than 2 times in 6 months or 3 times in a year, more than 3 times in a year, are considered to have frequent relapses. Those who relapse less number of times than that are considered to have infrequent relapses. On a final note, steroid-resistant nephrotic syndromes, meaning where the child has not shown a response to 4 weeks of daily steroids, needs a kidney biopsy and further management. Similarly, children who have frequent relapses are likely to need further agents to prevent the adverse effects of steroids. Thank you.